Happy New Year to all of us. May this new year 2021 be completely healthy. May all of us get an opportunity to remove this physical distance and meet each other in person, meet, greet, shake hands, hug each other. The vaccinations around the corner, and we have happy news coming in from DCGI just a few minutes back as well. Welcome to this live webinar on ISTH guidelines on diagnosis and treatment of TTP, conceptualized completely under the aegis of Mumbai Hematology Group. And we at INTAS are extremely proud of this collaboration and opportunity every Sunday morning. We are grateful to our program director, Professor Dr. M.B. Agrawal, who has made the entire Corona period so lively, enriching, academic, and an opportunity to interact with each other using this virtual platform. Sir, you are an institution. Sir, you are an inspiration. Sir, you are a teacher of teachers. And no wonder that you have got the inspiring hematologist of India from prestigious Economics Times. Thank you for making our day, our evenings useful. A very, very warm welcome to our chief guest, Dr. Srimati T. Shetty. A very warm welcome and Happy New Year to you, ma'am. And a warm welcome to our guest speaker today, Dr. Flora Pevandi. Madam, a warm welcome and Happy New Year to you. And all the esteemed panelists, apart from Dr. Srimati Shetty, a warm welcome and Happy New Year to all the esteemed panelists, Dr. Shukesh Chandran Nair, Dr. Neeraj Siddharthan, Dr. Prashant Sharma, Dr. Prabodh Kumar Das, Dr. Dipesh Lad, and Dr. Pritesh Chandrapatra. Thank you for making it so interactive. Last but not the least, warm welcome and Happy New Year to all the delegates from India, Kenya, Nepal, Bangladesh, United Kingdom, Myanmar, Sri Lanka, Malaysia, and many more countries. A very, very warm welcome to each one of you. Over to you, Professor Dr. M.B. Agrawal, sir.
Thank you, Manoj. I'll just share my screen. Screen visible?
Yeah.
Yes, sir.
So good morning, everyone. Today we have guest speaker, Dr. Flora Pevandi from Milan, Italy, who will be our guest speaker. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by ISTH. We are thankful to Mr. Manoj Kumar and his team from INTAS, Mr. Rajesh Sharma, Kalpesh Pambar, and the team from ISTH, Executive Committee of Mumbai Hematology Group for permitting me to do these activities. Our guest speaker, Dr. Flora Pevandi from Milan, Italy. Our chief guest, Dr. Srimati Shetty, discussants of today's webinar, and all of you for sparing your Sunday morning. Remember to ask questions, and I'm sure that our guest speaker will be most pleased to answer all of them. Do share the feedback form and collect your attendance certificate. Just to introduce you, next Saturday, Sunday activities. Next Saturday, 9th of January from 7 p.m. onwards, present President of ASH, Dr. Martin Tolman is our speaker on acute promyelocytic leukemia. And the next day, we have Dr. Philippe from Paris speaking to us on MDS. That's on Sunday morning, 11:30. To introduce our chief guest to you, you don't need to be introduced. Dr. Srimati Shetty is a phenomenon in herself. To complete the formalities for the youngsters, she's former scientist, F, Deputy Director, Senior Grade, National Institute of Hematology, ICMR, Mumbai. Her areas of expertise, out of which all of us have benefited, hemostasis and thrombosis and molecular biology. She's PhD in applied biology from ICMR, way back in 1997. Large number of awards, orations, and grants, and just to enumerate a few of them, the Young Scientist Award 1997, ISHBT, Hiranandani Award, Best Poster, MHG 1998, BGRC Oration, ICMR, year 2000, for the work on genetics of hemophilia, ISTH grants for the year 2003 and 2006 during the annual conference held in Birmingham and Geneva, Early Career Investigator Award from Bayer Healthcare USA, the annual conference of World Hemophilia Congress held in Bangkok 2004, BGRC Founders Day Oration by MHG 2011, JG Parekh Oration from MHG 2015. Responsible positions of international bodies held: Director, International Hemophilia Training Center, World Federation of Hemophilia; Member, International Society of Thrombosis and Hemostasis Quality Control Program for Genetic Diagnosis of Bleeding Disorders. Teaching experience includes, she's a guide for MSc and PhD in Applied Biology for Mumbai University, guide for ICMR, SERB postdoctoral fellows. It's published 264 articles and obtained 3 patents for her work. Today's discussants include, of course, Dr. Srimati Shetty herself, Dr. Sukesh Nair, Professor, Department of Transfusion Medicine, CMC Vellore; Neeraj Siddharthan, Clinical Professor, HOD, Department of Clinical Hematology at Amrita Institute of Medical Sciences, Kochi; Prashant Sharma, Additional Professor, Hematology, Department of Hematopathology, PGI, Chandigarh; Dr. Prabodh Kumar Das, Professor and HOD, Department of Medical Oncology, Hematology, AIIMS, Bhubaneswar; Dr. Deepesh Lad, Hematologist, Department of Internal Medicine, PGI, Chandigarh; Dr. Pritesh Chandra Patra, Assistant Professor, Department of Hematology, IMS SUM Hospital, SO University, Bhubaneswar. And now it's my privilege to introduce today's speaker to you, Dr. Flora Devandi. She was our guest in Mumbai Hematology Group 2 years ago, and she's very kindly accepted to be our guest speaker today to tell us all about the ISTH guidelines on diagnosis and treatment of TTP. First time these guidelines have come up, and they've just come up 6 months ago. She is Professor of Internal Medicine at the University of Milan and the Director of the Hemophilia Thrombosis Center at Milan, Italy. She received her medical degree from the University of Milan, Italy. She is certified in hematology and was awarded PhDs from Maastricht University, the Netherlands, and the University of Milan, Italy. And this was for her research in the field of rare bleeding disorders, which is totally her baby. Her basic and medical science research has focused on investigations of coagulation disorders. Her research in the prevalence and mechanism of coagulation disorders aim at developing cost-effective treatment for treatment of maximum number of patients worldwide. She's authored and co-authored over 310 scientific publications that have been published across well-known specialized journals and written 18 chapters in various books. Since 1999, she has been invited as an expert speaker to over 100 national and international meetings and congresses. She is recipient of over 40 project grants funded by Italian and international organizations, and she was the principal investigator of the establishment of a European network of rare bleeding disorders program. She participates in clinical, educational, research activities in different parts of the world. In fact, at present also she is in Iran, with whom she closely collaborates for this work on rare bleeding disorders. She was chair of the ISTH Scientific and Standardization Committee on Factor 8, Factor 9, and rare coagulation disorders. She is member of the ISTH Council, member of the Executive Committee of the World Federation of Hemophilia, member of the Executive Committee of the European Association for Hemophilia and Allied Disorders, member of the Medical Advisory Group of the European Hemophilia Consortium. In 2014, she was awarded the Great Hippocrates, which is given to Italian Medical Researcher of the Year. After introducing our chief speaker, we come to the quiz of the day. Like last time, I'm going to show you this picture, ask you a quiz, and request you to put your answers to the email ID. And as was discussed, the one whose correct answer reaches us first will get the prize like last time. So these are X-rays from a 28-year-old male who was seen for anemia of 2 months duration. And the question to you is, what is your best possible diagnosis for the etiology of anemia in this gentleman? So 28-year-old man, anemic for 2 months. This is the X-ray of knee, and you have to guess what is the best possible etiology of anemia in this gentleman. Email your answer to mbagarwal1@gmail.com. mbagarwal1@gmail.com. At the end of today's scientific activity, we will tell you what the answers were and who was the first one with the correct answer. And now it's an opportunity to listen to Dr. Srimati Shetty, our guest of the day. She is going to inaugurate our webinar and also give words of wisdom. Well, thank you so much for giving me this opportunity to speak to you. Over to Dr. Srimati Shetty.
Thank you, sir. Am I audible?
Yes.
Thank you for inviting me to be the chief guest of today's webinar. It's an honor to be the chief guest today for two reasons. First, today's speaker is a very close friend of mine. I know Flora for the last 20 to 25 years now. I think right since 1994. We made our entry together at Professor Manussi's center, that is Angelo Bianchi Bonami Center for Hemostasis and Thrombosis, of which currently she is the director. Both of us came with the same objective to learn hemophilia genetics at a time when nothing much was known about the disease, not only in India, but in many parts of the Western world. I had gone a few days earlier and I was struggling with the communication issues. As you know, the Italians love to talk in their own language, though all of them know English very well. So it was at this time, like a God-sent person, Flora made her entry, fresh after her post-graduation in internal medicine. She wanted to learn the genetics and the laboratory diagnosis of bleeding disorders. So both of us being outsiders, we became very close. In fact, Flora had hosted me on several occasions at her lavish bungalow, which was at the heart of Milan at that time. So gradually I got rid of my homesickness and we became quite close. So back home, if I had established the first genetic diagnostic center in the country, the credit partially goes to Flora besides Professor Manussi. Now, the second reason why I'm pleased to be here today is the topic which we are going to discuss, that is the thrombotic microangiopathies. It is always a clinician's nightmare. They are such dreaded disorders that whatever we know is very little because of the kind of heterogeneous clinical manifestations they present with. Be it diagnosis or management, it is always a complicated disease. And I don't think we could have asked for a better speaker other than Flora today. She's a master in all aspects of thrombotic microangiopathies, something very unusual for a clinician. She is also the main author of the guidelines for diagnosis and management of TMAs, which has recently been published in Journal of Thrombosis and Hemostasis. I'm sure along with me, the entire hematology community in the country is looking forward to hear Flora, her experience in these highly complex hematological disorders. Now, before I let the speaker in, I would also like to congratulate and thank Professor M.B. Agarwal for the continuous series of webinars MAG has carried throughout this rather very unusual period. 3 to 4 webinars in a month on clinically relevant topics, both in the area of malignant and benign hematology. It is not done just for the sake of doing it. If one sees the list of speakers, including today's, each speaker is an authority in the specific area of their expertise. In fact, the MHG has become a role model for other organizations to follow in the country. Many similar national organizations today are trying to simulate Professor Agarwal, but I'm sure none will be able to implement it the way Professor MBA does. On behalf of members of MHG and the whole of hematology community, I would like to thank Professor MBA for his untiring efforts in providing this non-stop educational program for the benefit of all of us. With these few words, I now formally inaugurate today's webinar on thrombotic microangiopathies. Thank you.
Thank you so much, Dr. Srimati, for all those kind words. And yes, you were the most appropriate chief guest for the day when Flora is the speaker. So that was, I think, planned in this way that you are here when she is the speaker. Also, thank you for all other good things that you mentioned about our activities and MHG. So now I think the floor goes to Dr. Flora, and we request her to give her talk. Dr. Flora, please.
I'm in line. Just want to thank
Good
you,
morning.
Sharmati,
I'm
for Dr. Peyvandi, Flora Peyvandi from University of Milan. I want to thank organizer for this very kind invitation, and I just want to wish you a happy 2021 with less problem, less disease, and more happiness. Is very sad and make me very unhappy not to be able to be in Mumbai with you. And I hope in the future we can be together and to be in the hematology group meeting, again, all of us together. My role would be today to bring the International Society of Thrombosis and Hemostasis guidelines on diagnosis and treatment of thrombotic thrombocytopenic purpura. These are my conflicts. Let's start with some background. What is thrombotic thrombocytopenic purpura? This microangiopathy, or TMA, and the patient who was affected was having platelet consumption with severe thrombocytopenia, red blood cell fragmentation, hemolytic anemia, and disseminated formation of platelet-rich thrombi in the microvasculature. The situation is bringing to the tissue ischemia at different organs like brain, kidney, and heart. And clinical manifestation of patient could change based on the vital organ that has been affected by the microtransformation. What about the pathophysiogenesis of this disorder? In the last 20 years, lots has been done to understand the role of metalloprotease Adams 13, which cleaves the von Willebrand factor subunit A2 domain at the tyrosine 1606 and methionine 1606 peptide. And this type of cleavage is leaving von Willebrand factor without any activity of binding to GP1B platelet and accumulation and aggregation of the platelet, and also the formation of the microthrombi in the microvasculature. If for any kind of deficiency, congenital deficiency due to the gene defect or acquired deficiency due to the presence of anti-Adams 13 antibody, this metalloprotease does not work, we would have the formation of the microthrombi due to the binding of this large glycoprotein, which is von Willebrand factor, to GP1B platelet and the formation of microthrombi. What is the clinical manifestation of this patient? The patient could have two situations, the combined situation of bleeding and microthrombosis. And the bleeding usually is associated with epistaxis, bruising, and petechia, sometimes gingival bleeding, hematuria, and women menorrhagia. The general type of symptoms is making very difficult the differential diagnosis in patient, like fever, jaundice, and the clinical symptoms like flu. And that's the reason why patient could go around for several days without any specific type of diagnosis. And the formation of microthrombi, as I mentioned before, depends on where it's happening. If it's happening at the cardiac level, we would have chest pain, heart failure, or hypotension. At the neurological central system, we would have confusion, headache, paresis, or aphasia, and that is when we have the microthrombi in the brain. And the same situation could happen also at the renal level with some sign and symptom like proteinuria and microhematuria. This slide is showing the type of clinical manifestation, both bleeding and microthrombosis in patients diagnosed in University of Milan. And as you can see, in both situations, when they were coming for the first event and for relapses, we can see for more than 240 patients, we have seen that bleeding symptom does not differ in the first episode compared to relapses. However, the most severe symptoms like neurological symptom, cardiac, and sometimes systemic syndrome are different. And that's because the patients, after the first episode, they get used and they are much better physician compared to us. They know their disease much better and they come with a very early diagnosis. What about laboratory diagnosis? And when you have a suspicion as a hematologist to have a patient with TTP with a sign and symptom that we have brought, what you're going to do? You make immediately a CBC to understand whether there is any hemolytic anemia, and you're going to find normocytic or microcytic anemia associated to reticulocytosis, increased level of LDH, and indirect bilirubin and consumption of haptoglobin. You have to make sure that you're going to make the Coombs test and you have a negative result. The level of thrombocytopenia and the severity depends of whether the patient is at the first episode or on relapses. And that could usually happen at the first episode with a level of platelet lower than 30,000 or even lower than 10,000. And the presence of schistocytes with more than 1%. So the peripheral blood smear is very important in your, I would say, laboratory testing in patients with suspicion of TTP. There was a consensus on the standardization of the diagnosis of TTP made a few years ago by Dr. Scully, and it was made very clear when you have a suspicion again of a patient clinically and after the lab test that we have seen, you need to make the differential diagnosis with other TMA based on the level of Adams 13 and the measurement of Adams 13 and its activity. If the level of Adams 13 is lower than 10%, you're going to make sure this case is a TTP case. Now, after this background, we're going to get to what has been done through International Society of Thrombosis and Hemostasis. And to do that, I'm going to come with first slide on what is the clinical practice guideline. A clinical practice guideline provides evidence-based recommendations for the management of patients and involve balancing the desirable and undesirable consequences of a given course of action. At ISTH level, we did have a preparation with experts on consensus on what is needed in terms of TTP, both diagnosis and treatment, And also there was a group of methodologists who were helping this group to understand what type of approach should be used. And the approach that has been used by GRADE approach was based on the recommendation assessment, development and evaluation approach, which provides a framework for rating quality of evidence and grading strength of recommendation in a structured, transparent and comprehensive way. Then the expert group had to come up with the PICO question, which was the important question on TTP on population, intervention, comparison, and outcomes. For example, 10 question, which was the priority for the expert group, was all-cause mortality, CV event, stroke, TIA, and neurological deficit clinically symptoms, platelet count recovery, relapses, and time to relapse, acute kidney injury in this group of patients, hospitalization, and exchange, exacerbation of the patient, means repetition of disease within 30 days from normalization of the platelet, and normal Adams-13 level. And different question in terms of diagnosis and treatment has been done. The guideline on diagnosis tried to understand the prioritization of the initial diagnosis steps to diagnose a first acute TTP episode to provide the optimal treatment. The question was whether for patients with a specified probability of having TTP, what is the impact of patient-important outcomes in terms of disease recurrence, mortality, adopting a specific diagnostic pathway, and consequent appropriate management. So it was very important to understand the role of Adams-13 testing and the outcome that I have shown. There were 3 potential diagnostic pathways. The scenario A was a pathway where Adams-13 activity measurement was readily available within 72 hours. Those centers that the physicians see the patient and they can have the test within 3 days. The scenario B was a pathway where Adams-13 measurement was not available, and the scenario C was a pathway where Adams-13 activity measurement was available with a delay after 72 hours. Then there was also the concept of treatment of relapses for those patients that were having already the diagnosis of acquired TTP, whether it was safe to make the confirmation of the diagnosis of TTP without any confirmation of Adams-13 low activity, this group of patients. So the calculating of the probability was based on clinical assessment and the former clinical risk assessment model. What are the clinical assessment and what were the clinical assessment model? For the clinical assessment, there was the scoring data based on the platelet count, less than 30,000, with the hemoglobin level and hemolytic anemia, suggesting TTP. There was a renal function with the serum creatinine less than 2.25 mg/dl, and the blood film, which was showing the increased number of fragmentation of red blood cells. And the alternative diagnosis also should be considered with those thrombocytopenia and or microangiopathic hemolytic anemia that are caused by other type of TMA. We also know that there are the risk assessment model like the French score and plasmic score. And the question was whether this could predict the severity of Adams-13. There is no doubt that they can predict the likelihood of severe Adams-13 deficiency. However, the use of a formal risk assessment model could not replace the Adams-13 testing. And that was very important confirmation coming from the ISTH guideline. That means you can use these models because you can increase the power of your diagnosis and the probability of your diagnosis. However, you do need to confirm the diagnosis with the Adams-13 testing. So both plasmic and French score were designed for adult population for no comorbid condition like pregnancy, cancer, sepsis, transplant, and this kind of scoring system could not be used and are not reliable in this condition and also in children. Therefore, for patients that we have mentioned before with the clinical sign and symptom and the laboratory test, you do need to make the evaluation of Adams-13 and to make sure that the level of Adams-13 is undetectable or is lower than 10%. Once that has been confirmed, you need to go with the anti-Adams-13 antibodies measurement, and if the anti-Adams-13 is negative, you are allowed to make the diagnosis of congenital TTP, especially if there are some family history over there and if the patient is a child. And regarding the treatment is completely different because just the infusion of plasma at this stage could be enough, and within 1 or 2 infusion you can have the response. However, if the result of anti-Adams-13 antibodies is positive, in that case, you're going to make the diagnosis of acquired TTP, and for the treatment, you need to act by replacement of functional Adams-13, removing anti-Adams-13 antibodies, and also down-regulating the immune system activation. And you're going to use different type of treatment to perform this type of improvement and also the treatment in this patient. And we're going to see what is the state of the art and how ISTH guideline is formed. As regards the congenital TTP treatment, the actual treatment is based on fresh frozen plasma, as I was mentioning before, and few centers around the world is trying also to use the inactivated factor VIII and von Willebrand factor, which contain a small amount of Adams-13. And only one product, it seems Kuwait, contains relatively high amount, and it still is not high because it's only 9 international units, and you need to infuse a significant amount of factor VIII, and that's the reason why we're going to see that ISTH guidelines sometimes is not very positive for the usage of factor VIII concentrate. And the novel therapy in the future would be recombinant Adams-13, which is in phase 3 clinical trial by very good result in phase 2 and also non-inferiority compared to the infusion of plasma. So what is the situation regarding the evidence that we have in the literature and what is the recommendation of ISTH? There is a sparse evidence with very low certainty. There is a regular plasma infusion, 10 to 15 ml per kg every 1 to 3 weeks reported by few studies involving the use of substantial infrastructure resources, and that is leading to an infusion of large volume of plasma and impose also some burden on patient. And there is also some concern about repeated vascular access and transfusion reactions using the infusion of plasma. And based on that, the recommendation number 7 of ISTH for patients affected with congenital TTP who are at remission, suggesting either plasma infusion or a watch and wait strategy. And of course, the clinical history in the family is important, and conditional recommendation has been reported in the context of very low certainty evidence. And you have to keep in mind, we have strong or conditional recommendation usually, and we have low, intermediate, and high certainty based on the evidence that we have. And in this case, due to a limited amount of data, conditional recommendation based on the very low certainty evidence. That doesn't mean we do not have to use the infusion of the plasma, because that's what we have available, but that's showing the level of the evidence available and how we have to design our clinical trial in the future. So based on non-clear evidence and on the benefit or harms and concern about the variability of ADAMTS13 concentrate in different factor 8 and von Willebrand factor concentrates, and the lack of understanding the mechanism of action of these products, again, regarding the usage of the concentrate, the ISTH recommendation suggests against the use of factor 8 concentrate versus a watch and wait strategy. And therefore, conditional recommendation in the context of very low certainty evidence. What about those patients with acquired TTP and the presence of anti-ADAMTS13 antibody? As I showed before, the treatment in this group of patients is much more complicated. However, we know that in the last 3-4 decades, the introduction of plasma exchange from 1991, I would say, in the last 3 decades, by Dr. Rock, instead of plasma infusion, reduced the mortality of the patient from 90% to 10 to 20%. And that, I would say, is a gold standard, and we have to keep in mind. What about the steroids? Lots of us used, and we are regularly using the steroids. However, if you look on the literature, there are not randomized controlled trials assessing whether the combination of PEX and steroid is superior to PEX alone. And despite very low certainty evidence, steroids may moderately reduce mortality in a life-threatening conditions and situation of patients affected with TTP. And the adverse events for the short-term use of steroids are generally not very severe. Based on that type of evidences, for both situations, patients at first event or even when the patient is on relapses, ISTH recommends the addition of steroids to therapeutic plasma exchange over plasma exchange alone. And the type of recommendation is a strong recommendation. However, there is a context of very low certainty. So that means if we put on the balance on the benefit and the harm and the cost and generalizability of the usage of a steroid, we can come up with a strong recommendation of the usage of a steroid in both conditions of the first event and relapses. What about the use of anti-CD20 antibody rituximab, which you know that has been developed for other conditions like lymphoma and subsequently have been used for the several autoimmune disorders, including TTP. And again, you can see few studies in the literature showed more than 90% of complete remission in patients affected with acquired TTP. However, if you look on the data accurately, data are not randomized. Therefore, there is a risk of selection bias. They are not clearly differentiating patients at the first acute event from those who are experiencing relapses. The primary effect of rituximab appears to be the prevention of relapses, not acute event outcomes. There are either 50 to 70% of patients may never relapse, and we might clear harms in those patients that they are not on relapses. And there are also issues related to drug cost, especially for those that are not using the biosimilars. So the resources, equity, accessibility, and feasibility altogether is just the expert group to come up with recommendation number 2 and 4 on first event and on relapses. And in both conditions, they are suggesting the addition of rituximab to steroids and PEGs over steroid and PEGs alone as a conditional recommendation in the context of very low certainty evidence. And if we could look on clinical situation of patient at remission, there is a difference in patients with ADAMTS13 level less than 10% during the remission. In those, the relapse-free survival was clearly longer in patients treated with the rituximab than those who were untreated. Based on that data, what we have to decide and how is the recommendation? I would say the same type of uncertainty that we have seen on the evidences and the non-randomized clinical trial, non-distinction between the patients at first episode and the relapses, and rituximab does not appear to affect survival. However, small non-randomized studies suggest that patients receiving rituximab have fewer relapses and require longer time for acquired TTP to relapse. There are also evidences with a limitation, and there are also some issues related, as I said, to the drug cost, and also we have to consider the issue of ADAMTS13 monitoring, which is necessary, and implementing rituximab prophylaxis without ADAMTS13 testing is not an evidence-based strategy and may lead to the possible overuse of this drug. And again, based on that data, we have recommendation number 6 during remission for those patients with acquired TTP who are with low ADAMTS13 level and no clinical sign and symptom. The panel suggests the use of rituximab over not using rituximab for prophylaxis. However, for the limitation that I have mentioned, the recommendation remain conditional in the context of very low certainty evidence. The last component that I would like to discuss with you, and is a newest drug that is used, called caplacizumab, is an anti-von Willebrand nanobody with a biological drive from heavy chain antibodies only. Caplacizumab binds to A1 domain of von Willebrand factor with the immediate inhibition of platelet string formation and consumption of platelets. With the proposal to faster normalization of platelet and reduction of tissue damage at brain, heart, kidney, and vital organs. There are 2 important studies, phase 2 Titan and phase 3 Hercules, as you can see, with a large number of the patients that have been enrolled, and that's for a rare disorder, I would say, is really excellent to have such a big studies. And with these 2 studies, what we have learned, this small component used at the acute state of the disorder is reducing the mortality and death with the significant reduction at exacerbation and relapses. For if you use the drug for 1 month after the normalization of the platelet. There are some bleeding events, mucosal type of bleeding. However, not large number of the patient, and just few of them needed the replacement of factor VIII and von Willebrand. So with acceptable safety concept in the usage of this drug. So what we have regarding caplacizumab, the data is becoming richer now because we are having more and more data worldwide and real-time data are coming. But at the time of the preparation of this guideline, there was moderate certainty because, as I said, there was 2 big randomized study, no doubt. One of them was double-blinded, but still the number were not enough, particularly for the mortality, because that could be risk of selection bias because the number were very low. No available data at that time, and I hope that data would be available soon on differentiation of the effect for the first event compared to the relapses. And also, in line with action of the drug, caplacizumab is protecting from von Willebrand platelet-mediated microthrombi, but is not resolving the disorder. And the disease should be cured by immunosuppressive therapy and plasma exchange for removing the microthrombi and also ultra-large accumulation of von Willebrand factor. And clinically, there was, as I said, some bleeding episode, not very severe. However, putting again on the balance, because that's a strategy for the guideline to keep into the consideration all positive and negative point and come up with a recommendation. So based on that, both first event and relapse, the recommendation number 5 for patients with acquired TTP who are experiencing an acute event, the panel suggests using caplacizumab, rather not using it, as a conditional recommendation in the context of a stronger, moderate certainty evidence. Therefore, the picture of treatment or the flow chart and the pillars of treatment is changing, and the new standard is moving from the blue part to the combination of the red and blue part of 3 drugs together, caplacizumab, daily plasma exchange until the confirmation of platelet normalization, and immune suppression using steroids or rituximab based on first evidence, first episode or relapses and the condition of the patient. And as I explained, caplacizumab is a drug with the immediate blocking of binding of von Willebrand factor to platelet with the immediate protection, and usually within 2-3 days, you can have the normalization of the platelet. However, as I said, you're not curing the disease, you're curing the symptom. And in the meantime, you have to follow up with immune suppression and cure the disease, as I have explained. When I'm making this presentation, there is a lot of discussion about in pregnancy, how we have to do and how I have to move on. For congenital cases, there is no doubt the usage of plasma infusion in pregnancy, because almost all women with low ADAMTS13 activity during the pregnancy needs the infusion at least once every 3 weeks or every 2 weeks. And I hope in the future with the recombinant product, we can have easier type of treatment. But in terms of acquired TTP, things are not so much straightforward. And there was a lot of discussion, what level is a protective level? And in our experience, with a well-designed study, however, with a limited number of the patient, we came up that 25% of ADAMTS13 could be a good level of balance for those women that could be protected from gravidic TTP. And as you can see, most of the patients who were having uncomplicated pregnancy, they did have a higher level than 25%. So my recommendation is very much similar to my experience, similar to what is coming from recommendation number 9 of ISTH for patients with acquired TTP who are pregnant and having decreased plasma ADAMTS13 activity, but with no clinical sign and symptom. The panel recommends prophylactic treatment over not prophylactic treatment. And this is a strong recommendation in the context of very low certainty evidence. And regarding the congenital TTP patient, as I mentioned before, for patients with congenital TTP who are pregnant, the panel recommends prophylactic treatment over not prophylactic treatment. And even here, there is a strong recommendation, even if we have a very low certainty based on the evidence of the data. And in recommendation number 10B, for those women congenital TTP who are pregnant, the panel suggests prophylactic treatment with plasma infusion over factor VIII product. And conditional recommendation in the context of very low certainty evidence. And at the last part of my presentation, just a few slides on long-term complication of TTP. And more data is coming to our attention about the problems that these patients are facing up in long term and how we have to monitor the ADAMTS13 activity. There was no data and we could not come up with a proper guideline on formal review of evidence, but what I'm going to report is a TTP expert practice with a limited high certainty evidence and yet evidence support for certain action. GPS statement for the long-term complication based on the published data suggesting shortened life expectancy. And the long-term complication are like neurocognitive with a memory loss, attention concentration defect, and these patients could have really low quality of life by emotional depression, anxiety, hypertension. They have to change their job and the quality of their life is changing significantly. And that's the reason why it's very important as soon as possible to come with a normalization of the platelet and avoiding the formation of the microthrombi, especially at the brain and heart and kidney. So monitoring for this complication is very important. And how we're going to monitor that? The patient should regularly be seen and followed by monthly measurement of ADAMTS13 in the first 3 months after the normalization of platelet, and also after when after 3 months, you're going to start to see the patient every 3 months for the first year, and then you might increase the interval up to 6 to 12 months. So more frequent measurement of ADAMTS13 need to be done when you can see there is some sign or clinical manifestation. And of course, you might even decide to reduce the interval if the patient is starting to have low ADAMTS13 activity. For example, if you have a woman who is pregnant, you might want to reduce this interval, or if you have a patient who needs the surgery or has some kind of associated disorder. So ADAMTS13 activity interpretation should be stably near or above normal, and that's really reassuring. And if you can see that the patient starts to have less than 20–30%, that means the persistency is low and there are the risk of relapses. So we need to have more and more data, and I hope in India you have to have more and more national databases, and at least trying to put your data together and understanding better how you can manage the patients affected with TTP during the acute disorder and during the relapses. And with this one, I want to thank you again for this invitation, and I hope I answered most of your question in the management of the patient, and especially for those hematologists that are seeing during their activity this kind of rare disorders. And I'm very happy to get any question or any comment from you. Thank you.
Thank you, Dr. Flora. That was an excellent presentation. You were instrumental in developing these guidelines, and today you have put them to us in a very simplified fashion so that everybody can understand what these guidelines are. And I think that will be a practice-changing event in this country. All these guidelines will help us in proper management to the patient. So we have a lot of faculty present over here.
Thank you very much.
Dr. Srimati, you have your question?
Yeah, Uh, Flora, FRET is the gold standard for ADAM-TS13 activity. And there are 2 or 3 other assays too, like VWF, CBA, RECOF, and immunological assays. I mean, I have seen your JTH paper, the last paper what you published. And they have come out with, these are the pool data, they have come out with a very good sensitivity and specificity, almost equal to FRET assay. Like in India, we have only 2 or 3 centers doing FRET assay for ADAM-TS13. There are a lot of other logistic issues too, transport of the plasma, urgency of the report. Now, my question to you is, can we substitute RECOF or CBA or immunological assays to FRET with the
Thank,
compromising a little bit on the sensitivity and specificity?
Very good question. First of all, let's to tell hi and good morning to everyone. Again, thanks very much for your kind words, Shirmati. It is lovely to see you. And I'm so sad really not to be in India with you, because if I'm missing India every 2 years, I feel really uncomfortable, and this is becoming 3 years. So let's hope that we can see each other very soon.
Sure.
And thank you very much to Dr. Agarwal and all organizer. I think it's a fantastic idea to have for the rare disorder space. Thanks again for the question, because I think your question is pointing out difficulty, as you mentioned. So there are 2 types of difficulty. First of all, none of the assay that you clearly mentioned is reporting the real activity of ADAM in terms of the physiologic activity. Because what you're going to get is von Willebrand factor, a piece of von Willebrand or the full length in an unphysiological condition, denature it, and to see in presence of plasma whether ADAM13 is working or not. And we are not even sure that is really reflecting what is the physiological condition. So that's a big challenge we know in the last many years, and still there is no solution for that. And when we try to do it in the flow system, the sensitivity was not going lower than 30%. So that's a main issue. Within the different assay, there is a difference between the time consuming, cost, management, and depends what is your question, Shirmati, at this point. If you're working in emergency and you need to have a very fast answer, if there is or there is no activity, and you do not care about what is the exact activity, I think you should choose cheapest and the fastest. And of course, you sacrifice sensitivity, but you're going to get the highest sensitivity because that's the most useful action to do. But if you are monitoring patient because you are making immunosuppressive therapy, this is a pregnant woman, you want to decide whether to have PEX for the prophylaxis, then you need to have a more accurate assay, and you have to be very cautious about the type of the assay you are using. So I think the FRET assay, to my opinion, is one of the best assay to use it. And of course, it's an expensive assay. It still is expensive assay. Yeah. IL came over with a chemiluminescence assay recently. And that assay is interesting in terms of sensitivity, specificity, and also in terms of the time. So in 37 minutes, you have the result. And in emergency, that's very important for you. It's a problem of cost. I had a lot of discussion with the company. And last week, fortunately, I have some news from them that I learned how it's important to reduce the cost of the assay in order to be used worldwide from the hematologist. And I hope this is a real answer they gave to me for 2021. So check with them. And if that assay is working, is really good.
All right. All right. Thank you.
Thank you, Dr. Srinati. Before we go to Dr. Neeraj for his question, we have certain questions from the participants. 312 participants have listened to you, and lots of questions are there. Let's hope we can cover some of them. There are a lot of clinicians who are listening to you, and they want to know, till the results of ADAMS 13 become available in the clinical practice, in a patient of microangiopathic hemolytic anemia with thrombocytopenia, how do you pull out that this is a case of TTP from other causes?
Very good question. I apologize if I didn't bring it because of the time limitation. So what you have to do is still the clinical evaluation is the most important thing. That means if you have a low number of platelets and you have hemolytic anemia and with negative CUMS, and you do not have the alteration at the renal failure in terms of requiring dialysis, you are allowed to think about the microangiopathy and start the PEX and steroid therapy. And in the meantime, get a plasma sample without the infusion, because that is making a alteration in the measurement of Adams-13. So send a sample and start the PEX and a steroid and wait for the result of Adams-13. There is a flow chart in the guideline of in the publication of the ISTH. I didn't bring it, but it's very important if you can have the result of Adams-13 within 72 hours. If you can have it within 72 hours, you start also caplacizumab, because you're going to get really the results very quick in 2-3 days, and damages at the brain level is much lower. And wait for the result. If the result is confirming, you continue the three drugs, as I said, PEX, steroid, PEX, rituximab, and caplacizumab. If the result is showing normal Adams-13, stop with capla and continue with PEX or with a specific drug. For example, if that's a HUS, you're going to go to lituximab and the type of treatment is changing. But please do not wait 13 for starting the treatment. Otherwise, you're losing your patient.
Thank you. Neeraj, your question, please.
Thank you, sir. Good afternoon, Dr. Pevandi. Excellent talk. Thank you very much. My question to you is, with respect to the plasma exchange. Now, starting from putting in a catheter, we are asked several questions. Whether is it safe to transfuse platelets? Is it safe not to transfuse platelets? How often should you ferrous? Is it once a day, more than once a day? And what is the intensity of plasma exchange that you should be done? And when it should be decreased and when it should be stopped?
Okay, thank you very much for your question. And the reason, I just want to let you know, because that was a very interesting experience for me for this TTP recommendation preparation, because there is so many questions, as you said, we have, and we came over as an expert to decide how many questions we have to put. And the cost of preparation of your guideline is increasing. For example, a guideline like this is going to cost you $300,000. And if you add any question, it's jumping up. And that's the reason why we couldn't include, of course, all questions. But go back to your text first. No, let's go to talk about platelet. Platelet infusion is contraindicated, and you do not have to use it. Only is allowed when you have the anesthesiologist coming to get the central line and the platelet is so low and they are not getting the central line for the PEX treatment. And in that case, you can do it. But I had patients with a very severe Adams-13, acute TTP. We were giving the platelet and he was producing the microthrombi, and you could see the symptoms like a stroke. So it's like really to put the oil on the fire. You do not have to use the platelet if you are not having an extreme big problem of bleeding in the patient, because the problem here is not aggregation. Also, you do not use aspirin, for example. It's not aggregation of platelet. It's from Willebrand and platelet. So the treatment is what I said: no aspirin and no use of platelet. You are allowed to use, of course, the red blood cells in case of anemia. For the PEX treatment, start with 1 exchange a day, and usually in Europe, you are not exceeding that, also because of the overload. And if the patient have the problem of cardiac failure, that could be dangerous. But in the States, they are having a habit to use twice a day also if it's needed.
Thank you.
Thank you, Neeraj. And before we go to Dr. Prashant's question, we have questions from the audience related to secondary acquired TTP. Do you search out for the causes like SLE or associated thyroid disease and other autoimmune disease, Sjogren's syndrome, etc., in every patient? how do you proceed?
Excellent question again. I think definitely when you are seeing the patient, the first episode, you have to rule out there is an autoimmune disorder associated to the acquired TTP. And why that is important? Because that's changed, at least my behavior in Italy, the intensity and strength of the immune suppression. Because to my opinion, when you have only acquired TTP without any autoimmune disorders, you might use a lighter type of immunosuppressive treatment during the remission. But when you have a disease like SLE and other type of Sjogren or something like that, you might need during the remission to use a proper immunosuppressive therapy because you have the endothelium always active and always the inflammatory situation is there and the risk of relapses is much higher. So that's a very important question. You have all to make sure this is the secondary or the primary TTP.
Thank you, Dr. Flora. Dr. Prashant, your question.
Thank you, Dr. President, for a very nice talk. My question is about a situation that we sometimes encounter where a patient has already been transfused by the time TTP is being suspected. And of course, if the suspicion is high, then one proceeds without, regardless of the test results. But in patients who have low or moderate pre-test probability, do you still go ahead with the antibody testing, or what is your approach in such cases, diagnostically?
Yes, very good point again. Right, because usually when the patient are coming to the referral centers, they already had at least one infusion. In my personal experience, when the patient is very severe, you cannot with one infusion to lose all the antibody formation. And it might interfere with measurement of Adams 13 but it's very difficult not to detect anti-Adams 13 antibodies. So what I think you should do in that case, you have to base yourself on the clinical manifestation of the patient, presence of schistocytes, non-presence of renal failure, which requires dialysis, and to put all the scores together and come up with a more probability of having TTP. And then, of course, the final real conclusion could be done once the patient is 2-3 days without the PECs to understand whether the level of Adams 13 is very low. But I would treat the patient as TTP.
Thank you, Prashant. Before we ask question from Dr. Prabodh, again, there are questions from audience. In a developing world where cost constraints are there, do you still recommend splenectomy as a treatment for recurrent relapsing acquired TTP?
I prefer not to recommend the splenectomy as ITP, the TTP even more, I would say. I can understand if there is no possibility, it should be really the last decision because you're losing your patient. And in that case, of course, you can't do anything else. But I think with the biosimilar, and India is very strong in the formation of the biosimilar. I don't know if rituximab biosimilar are available. So the cost is really reduced. And this correct usage, for example, you can use azathioprine, you can use cyclophosphamide, different type of immunosuppressive treatment, but I would avoid the splenectomy if it's possible.
Thank you. So can we have question from Dr. Prabodh? Prabodh, are you there?
Yeah. Thank you, Professor Pivandi, for your nice lecture. Are you able to hear me?
Yes.
Yes,
Yeah.
very well.
So the issue is that with the non-availability of ADAMT3S mutation in India, particularly, what would be your approach? How do you distinguish between atypical hemolytic uremic syndrome and TTP?
Good point. As I said, you cannot be sure, but the clinical manifestation of patients with TTP is more neurological, particularly at the first episode. And HUS, much less neurological, I would say. The kidney failure is much more strong in HUS patient. However, there might be some kind of alteration, but the creatinine level is not really jumping, which requires dialysis in the TTP. And these two factors, I think, are important for the distinction of TTP. So if a patient is coming,
We'll just wait for her to get the network back.
Dr. Flora has just logged out. I think
Oh,
her
she's
internet
lost.
connection is
Yeah,
unstable.
lost her network. We'll just see for a few seconds if she can get her network back.
Yes, sir.
She had indicated that network is a problem in Iran where she is there at the moment. So, okay, what we can do till she can get the line back, we can discuss the quiz that was put to the participants. So we have about 12 answers, and I will like to first tell you the names of people who have made attempts to answer, because that itself is very creditable. We have Dr. Navid Tamboli, Dr. Asad Syed Muhammad, Dr. Amit Khurana, Dr. Anil Malani, Dr. Danushka Disanayake, Dr. Neeru Singhal, Dr. Karthika KV, Dr. Pujitha Reddy, Dr. uh, Kunal Goyal, and Dr. Samir Goswami. These are the people who have tried to answer the question. Yes, and Dr. Kulkarni, Dr. Surekha Kulkarni. So we have 13 people who have tried to answer the question. So Flora is not yet back. So there are two out of these who have. Yeah, Dr. Flora is back.
yes, I'm just trying. I'm sorry because the internet connection is really difficult here.
We understand. Please go ahead.
I'm sorry for that. So the question, it was on the differentiation of the HUS and TTP. I don't know if you heard what I said. So neurological symptoms, not really kidney failure, which requires dialysis, and that's it, I would say. That's the distinction, the important distinction that you can do.
Thank you. Thank you, Dr.
Great.
You're
So
welcome.
Dr. Deepesh will be asking next question. And before that, we have some questions related to targeting the plasma cell as the treatment of TTP. And do you feel there's a role of bortezomib and even daratumumab?
Bortezomib, it was the question?
Yes. Targeting the plasma cell as the treatment, including bortezomib and daratumumab.
I have the experience for just one patient, which I used the bortezomib because I was desperate, and the patient was so resistant, was not responding to any kind of treatment, and the results was good, I have to say. But I prefer not to use it if you can use the regular treatment that we have mentioned. And of course, in those very, very rare cases, they are not responding to any type of treatment, and we know as a clinician we are desperate, that is allowed.
Thank you. Dr. Deepesh, your question, please.
Thank you, Dr. Flora, for giving us the guidelines on TTP. So my question is related to drug-induced TMA and transplant-associated TMA. How do you manage those in the absence of guidelines?
That's the most difficult part of the patient, and mainly, to my personal opinion, they are not responding to PECs. And however, we still use the PECs, and I feel that type of treatment is more for the physician because they are desperate and they don't know what to do. And unfortunately, the mortality in that group of patients is much higher. So I think the responses could be there when there is a start of the TMA, because there is an endothelium activation. And when the endothelium activation is starting, as you know very well, is very, very difficult to stop it. And that's a similar things we've seen also in the COVID situation, when you have the endothelitis. And I would say there is no specific treatment in that group of patients, unfortunately. We use PEGs with a very low response.
Thank you. The next question will be from Dr. Pritesh. And before that, once again, there are questions related to plasma versus cryo-poor plasma. What is your preference?
There was a lot of discussion long time ago, I would say about 15 years ago, whether there is any difference between them. And I think there is no evidence really to come over whether there is the big difference. Of course, the accumulation of ultra large, especially if we do not have a good tool to get rid of the large multimers, so it would be better not to use a very dense and rich plasma with the ultra large. There is no really big evidence showing the difference between the two strategies.
Thank you. So, Dr. Pritesh Chandra, your question.
Thank you, MB Agrawal sir, for allowing me to asking one question. There is a scenario in which I want to ask a question. That suppose a patient of TTP in his initial period of management with the plasma exchange, and he relapses within 1 to 2 months. How will you address this patient at this point of time, Dr. Flora?
So you are talking about within a month or after a month?
Within 1 to 2 months.
Okay, because that's the definition is changing. Because within a month, if you have the possibility to use the caplacizumab, you have to use it for a month. And that means you are sure there is no accumulation. Even if the disease is not cured, you have the possibility not having the accumulation. If you don't have the caplacizumab, which is happening in a large number of the countries around the world, I think what you can do, first of all, you have to make sure that the number of the platelets when it's getting normalized, at least for 2-3 days, is normalized. And you have to see your patient more frequently, as I was saying, to make sure that there is no jump of the platelet. For example, some of the centers are making the tapering of plasma exchange. We do not make the tapering. We just stop if 3 days the number of I would say the number of the platelets are normal, and the level of Adams 13, of course, we're measuring. If the level of Adams 13 is low and the number of the platelet is normal, then you can use the tapering. For example, to make 2 PEGs a week, and then just reduce it to once a week and then stop it until the normalization of the Adams 13. And after a month, we just visit the patient, as I said, for 3 months, once a month, but we are not using any specific treatment. But if the level of Adams 13 is low, in that case, if the patient even have a single episode, we use the rituximab in order to increase the level of Adams 13.
Okay. Thank you.
Thank you, Dr. Pritesh. So once again, we move to the audience. There is a question related to the site of thrombi in TTP. Is it arterioles, venules, capillaries, and are the major vessels involved anytime?
Good point. Mainly is a microvascular arterials where the shear stress is high, and that's the reason why ultra-large von Willebrand factor is getting strange and is binding to the platelet. I have to say the histochemistry is not really so evidence-based, because the data is going back to a few years ago when the etiopathogenesis has been done, and more data is needed to make sure that the involvement is only specifically for the arterial. I would say the most specific symptoms, you can see it in the microvascular cell and the arterial. However, I'm not sure in the venous. there would be no role of Adams 13, and we are seeing more and more the role of Adams 13, and some of the patients even had the pulmonary emboli. I don't know if that's a causality or is just a correlation, and by chance there was this type of thrombosis at the time of the TTP. But mainly I would say where the shear stress is high.
Right. There are questions related to the degree of thrombocytopenia. It is generally presumed that these patients have very severe thrombocytopenia, but are you safe in diagnosing TTP if the platelet count is over 100,000?
This is important question, and usually, as I said, the patients at the first episode is very difficult to come to your observation with 100,000. That's going to happen by chance, and that might be some of the heterozygous, for example, patient, and that have an important role also in neonatology. For example, those kids that have congenital disorders, and they are not as an acute episode of TTP, but just been observed with a mild thrombocytopenia. So I think the measurement of Adams 13 is becoming very important in most of the people where the level of platelet is lower, and there is no justification for it. No ITP, no other type of sign and symptom could justify the low platelet. I think you have to measure Adams 13.
Thank you. Also questions related to pregnancy as the first presentation of congenital TTP. How do you explain the patient remaining silent up to 2 decades?
Okay, I did a lot of work with Dr. Ferrari in my center. When I started, the women were coming from all over the world to my institution, and they were saying, I want to be pregnant. And every doctor is just looking me so badly when I'm talking about pregnancy. I'm one of those doctors, which I know the danger of the pregnancy and TTP, but I think it's the right of the women to be pregnant, and we have to make sure that we are covering them. And culturally, I mean, we are in India, in Persia, and this is culturally important for these women. And we have to, of course, when there is a danger, we have to be serious doctor and to say, no, forget about it. But when we can help these women, I think we should. And with the normalization of Adams 13, there is a good chance in the last 2-3 years, we did not have any case of TTP or the death in our women who were pregnant, because we are monitoring them and we are making a plasma exchange monthly, trying before the pregnancy, treating them with rituximab, normalization of Adams 13, getting pregnant, looking on the level of Adams 13, and trying with the PECs, go to the 9 month and make the delivery. So I think you should be sure, first of all, the woman culturally is understanding and educationally what you are talking about. Because if that's not the case, it's better not having the pregnancy, because you're losing the mom and the child. If the woman is understanding and is helping your doctor, it's a big work. And I'm always saying them, before your husband, I should know that you are pregnant, and I have to manage your pregnancy. And I think with that one, you can do it.
Thank you. The questions related to mutation studies. Is there a place of NGS studies in clinical practice?
NGS mutation analysis, you mean?
In clinical practice, is it relevant?
I think in future, to my opinion, with a lower cost of the NGS, I hope it could be one of those centers in the future, that with the chip, we can have all the mutations related to the clotting disorder. That is what I'm doing, trying to establish in Milan, and actually we are doing that. We have a patient, it's much more convenient to have all alteration in one single chip instead of going for the single genetic analysis and the sequencing analysis. I think that would be possible, but of course, still we cannot use it for the diagnosis, and it's for research. The future would be for the diagnosis.
Thank you. The questions related to doing troponin I repeatedly in patients of active TTP. How often do you do this to look at
We never do it.
You don't do it?
We never do it.
Okay.
We never do that.
cardiac is not an issue.
A troponin level. Oh,
Troponin,
sorry.
yes.
Troponin level. Sorry. I
Yeah.
thought erythropoietin levels.
No.
Troponin level is a very important point, actually, at the beginning, especially in emergency. And very few centers, unfortunately, they are doing, because this patient might not have the proper myocardial infarction sign and symptom in the ECG, but they have the cardiac tissue suffering. And I think troponin should be done definitely at least in the first 3 to 5 days in order to make sure that there is no failure, cardiac failure. Thanks for this question. It's an important point.
And do you repeat it often if patient?
We do. If it's normal, we do not repeat it, especially if the number of the platelet is increasing and the condition of the patient is stable and is not worsening.
The question related to N-acetylcysteine, NAC, is it useful?
No, that has been by the Jose Robles group has been reported for, and I think it's a clinical trial ongoing, if I'm not wrong, is in phase 3, and the results of phase 2, it seemed to be interesting, but I think the dosage, frequency, and all the side effect, this kind of information is not yet, so I'm not using that in our center.
And one last question from the audience is, how common is drug-induced TTP, and which drugs are common in your practice to create TTP?
Yeah, good point. There are some, like, for example, for India, it would be more anti-malaria drugs, and there are some of the anti-aggregant therapy. However, the number of the reports are very limited. And again, it's very difficult to explain the association of the drug and the comparison of the TTP. Of course, if you have a patient with a history of TTP, you do not want to use, for example, this specific antibiotic or anti-malaria or anti-aggregant that has been reported to be associated. But to be very honest, if I have to talk about the ISTH guideline, I think the data are very, very limited to come up with a clear-cut evidence-based data and to say what category of drugs are really reporting the TTP. I think for anti-malarial, you need to come up with that type of data because you have much more data compared to us.
Thank you, Dr. Flora. We promised you that we will release you at 1 o'clock Indian time. There are lots of questions lying in the question box, and I'm sure the faculty over here also is quite jittery to ask you more questions, but we will keep our promise. We will release you at 1 o'clock. Maybe we can send you these questions by email and you will help them out. Is that okay for you?
Yeah, I mean, if you want, still I have 3, 4, 5 minutes because yeah,
Any
don't worry.
question from the audience here? From the participants here? Faculty who is present here.
Dr. Flora, I want to ask one question. Can the addition of caplacizumab reduce the duration of attending the patient's remission and duration of the hospital stay?
Definitely, yes. I couldn't bring the data. Actually, that's the reduction of the plasma exchange and reduction of the hospitalization is the most important issue that you can see. So is learning how to manage the patient is important because with Kapla, immediately after 2-3 days, the platelets are jumping. It's very important if you are using the immunosuppressive and with which speed the amount of atoms is jumping. Definitely, yes.
And during the initial phase of treatment and during relapses, what steroid would you prefer, and for what duration do you give?
The Kapla, you mean?
No, steroid. Which steroid do you prefer?
Okay. Steroids usually we use for 2 weeks, and then when normalization of Adams 13 and especially the platelets is starting become, I want to close with the steroid for not longer than 1 month, to be honest, because I'm not one of those physicians. I don't love use steroids for a long time, and if the patient is coming still to have the low level of Adams 13, as I said, I'm using rituximab. And otherwise, in some patients, they have a very good experience to use the azathioprine.
Okay. And
And of course, you have to check the toxicity of azathioprine at the beginning.
and the maximum, how many doses of rituximab you have used in your practice? 4 doses, 8 doses?
You use 4 doses. You measure Adams 13. If Adams 13 is normal, that's enough. If it's not normal, up to 6 doses, not more than that.
Okay. Thank you, Dr. Flora. Thank you very much.
If you're using rituximab in the interval between the relapses, when the patient is in remission, you are trying to keep the Adams level at around 40%?
Yeah, I would love not to have lower than 20-30%.
Not lower
That's,
than 30%.
yeah. And usually, you know, with rituximab, if you have the rituximab response, usually it's jumping. The problem is the interval. So how long time this response is remaining? In some patients, 4 years, in some patients, 6 months. And how safe is repeated for how many times? That type of questions are important. And some of my physicians, for example, they don't love to use so many times rituximab, and they use the azathioprine because they think it's better. Actually, there is no really guideline for how to use in the rituximab for the remission and how many cycles.
And suppose those patients with relapses, is there any role of obinutuzumab or ofatumumab?
As I said, I have experience with only few patients. They were not responding to rituximab. And I had one patient respond actually to both rituximab. And I would then use for the first line, but for the second and third line, yes.
With Kapla, bleeding is a real issue or it's not a big problem?
No, for me not, to be honest. Because if you know how to use it, because at the beginning when Kapla came over, we were all really lots of fears. No platelet, Kapla with von Willebrand doesn't work. What's going to happen? But you know, I didn't see. I see only one menorrhagia in a woman who was in pre-menopause, and she required the treatment with factor VIII with one dose, but not big issue, I would say. In the balance of the benefit and the side effect, I would definitely go, the benefit is much higher.
Thank you, Dr. Flora. I think we will release you. We are grateful to you. We will continue this meeting and we will send you these remaining questions by email, and I'm sure you will help us out.
Absolutely. Don't forget that I'm looking for the face-to-face meeting in India, and I hope really we can get rid of this COVID-19.
You will be our guest very soon.
Thank you very much, and all the best to you, to share Mati, to all the physicians and all those people who attended this meeting. Thank you very much.
Thank you, Dr. Flora.
Thank you very much.
Take care. Have a good day.
Thank you. We will continue with our quiz that we have to discuss. And I'll just bring that quiz slide again to you. Can you see it?
Yes, sir.
Okay. So that's the slide that was shown to you, X-ray of the knee joint. And I already mentioned about the name of the people who have attempted to answer, 12 of them or 13 of them, and that's wonderful. And that's why it was very important to speak out their names, because they made attempts. Now, I'm not going to tell you who answered what, but I'm going to tell you what are the types of answer we have received. So we have a answer that this is synovial chondromatosis, dystrophic calcification. Now, being a hematologist, I don't know what this entity is, but I will just guide the audience that probably the quiz will be always hematological. Even the person who is forming the quiz may not be aware of non-hematological conditions. So you can keep that kind of context in mind while attempting these quiz questions. Another answer that I have is that this is sickle cell arthropathy. I'm afraid you don't see this in sickle cell arthropathy. The arthropathy of sickle cell disease is all related to ischemic damage. You get avascular necrosis of femoral head and other joints and so on. The other question I have, answer I have is hyperphosphatemic tumoral calcinosis. So once again, I don't know what this entity is. It's not a hematological entity, and that is not the correct answer. The other question is, answer is hemophilic arthropathy. So once again, hemophilic arthropathy, of course, is very close to us. And what you see, this joint space is the one which gets lost. And the joint space over here is beautifully maintained. So this is not just calcified blood lying in a hemophilic arthropathy. The other answer I have is this is anemia of chronic disease, probably renal failure, and this arthropathy is related to kidney failure. I'm afraid kidney arthropathy is a very unusual entity, and you don't get this kind of picture there. The other answer I have is uric acid crystals in the knee joint because of chronic renal failure, and anemia is due to chronic renal failure. Once again, I'm afraid uric acid deposition in the X-ray won't look like this. We have another answer is this is a pseudo tumor. So once again, that comes to closer to hemophilic arthropathy causing pseudo tumor. Another answer is that this is multiple myeloma. Again, I'm afraid multiple myeloma gives you those classical punched out areas, and this is not that. That covers most of the wrong answers. The one answer which was reasonably close but is not the exact answer is that this is the damage to the knee joint by lead. So this I will tell you the name of the doctor, Dr. Samir Goswami. Dr. Samir, you are halfway all right, but this is not exactly lead-induced arthropathy. And then I come to the two people who have answered the correct answers, and that is Dr. Surekha Kulkarni and Dr. Navid Tamboli. So you know what exactly you have answered, and you are right. The anemia is due to lead poisoning, and that is the correct answer. The question was that what is the best possible diagnosis for the etiology of anemia? And what you see over here is the X-ray of a soldier, a 28-year-old soldier who fought the Kargil war and who had a bullet in his body. And that bullet was lying unnoticed near his knee joint in the soft tissue. And that bullet, the lead in that bullet led to the genesis of lead-induced hemolytic anemia, or the complex pathogenesis of lead-induced anemia. So this patient had hemolytic changes, this patient had punctate stippling, this patient had ring sideroblast in the marrow, and the hemoglobin was around 7 grams. And he got referred because of the anemia, and actually he had almost all other symptoms of lead intoxication, including constipation, abdominal pain, certain changes in the neurology, and so on. So this is the correct answer, and between two of you, Dr. Naved Tamboli and Dr. Surekha Kulkarni, the difference is very marginal, 1 second difference. And the winner is Dr. Surekha Kulkarni, and Dr. Tamboli, you are just 1 second after Dr. Kulkarni. So congratulations to both of you, and the prize will go to Dr. Surekha Kulkarni. We have some time left because Dr. Had to leave, Dr. Flora had to leave. If anybody from the participants here want to discuss anything before I ask Manoj to call it a day and give the official vote of thanks. So if there is nothing, I'll request Mr. Manoj from INTAS to deliver the vote of thanks.
Sir, actually, I wanted to ask regarding the availability of caplacizumab in India and
so I'm afraid Kapla is not available in India. And I'm also afraid that those guys who import drugs for you and me and supply Kapla, the per day cost comes to about 2.5–3 lakhs. And as you know, this is subcutaneously to be administered on daily basis. And as Flora said, that you continue it for a month after the whole episode is controlled. So even if Manoj on behalf of INTAS makes Kapla available to us,
Will
I'm
not be able to
concerned.
deliver the prescription.
Yeah, I'm concerned about it.
Okay, sir.
Rituximab maintenance also during the interval phase, there are issues with the patients, even with the generics available. 4 doses are all right, but if there is a long gap and the Adams level is low and you want to keep giving rituximab maintenance, besides the side effects, the cost does become an issue. Like, your follicular lymphoma, you want to give rituximab 12 doses. There, at least you tell the person 12 doses and full stop. Here, you can't put a full stop anywhere.
Yes, sir.
So
Thank
Manoj,
you.
homework for you, get Kapla to us.
Sure, sir. Points noted. I was making a notes. So hopefully some solution would surely be possible. But for the time being, we have rituximab. I think the whole nation is waiting for the vaccines. And that is the most awaited one. I guess if all of us are vaccinated, uh, a lot of goodwills would also follow. So thank you so very much, sir. You have always been a wonderful academician and you have pulled off another blinder, another wonderful webinar together. Thank you so very much. And also a big thank you to our chief guest today, Dr. Mrs. Srimati Sethi. Thank you, ma'am. And two of you wonderfully working together in Italy and you coming in and forming your first lab in India. That was wonderful to hear. Dr. Flora Pevandi, in your absence, a big thank you from all of us. And all the expert panelists, Dr. Sukesh, Dr. Neeraj, Dr. Prashant, Dr. Prabodh, Dr. Dipesh, and Dr. Pritesh for making it very lively. And sir, we have again a lot of participants across the world. India, Kenya, Nepal, Bangladesh, United Kingdom, Myanmar, Sri Lanka, Malaysia, and many more countries. A big thank you and Happy New Year to each one of you. And may this year be completely, hopefully, end of the year for sure, be corona-free for all of us. Thank you very much.
Thank you, Manoj. And thanks to all those 320 audience who logged in, and the faculty here, and the chief guest, and the speaker. On my behalf, thanks to everybody. On behalf of Mumbai Hematology Group, thanks to everybody. And a big thank to Mice Ideas and a big thank to Manoj.
You're welcome, sir. Bye-bye.
Bye.